Hello, my name is Ruth Gilbert and I'm presenting abstract number 37 in standard track 1. The title of my talk is EChild, Education and Child Health Insights from Linked Data, a new resource for evidence-based policy. In the next 20 minutes, I'm going to tell you about EChild and what the EChild database contains. And I'll discuss how this resource can be used to inform evidence-based policies. I come from a health background, having trained as a paediatrician before becoming an epidemiologist. And as co-director of the Department of Health and Social Care Children and Families Policy Research Unit, I see how policies across government impact on children and how linked administrative data can contribute to evidence to inform those policies. So first, I'm going to tell you what the EChild database contains. Second, I'll say a few words about the governance challenges and the need to maintain public trust. Third, I'll discuss linkage and linkage challenges. And lastly, I'll talk about future innovations, and I'll be really interested in your suggestions in the discussion section. So what does EChild contain? The EChild database combines routinely collected hospital data called hospital episode statistics with routinely collected data from the National Pupil Database, which contains education data and social care data for all children in England. The linked database contains nearly 15 million children and is accessed in the Office for National Statistics secure research environment with strict outputs and access controls. The data is de-identified, which means that it cannot be used to re-identify people, and it contains no real-world identifiers such as names, date of birth, or postcode. EChild has been established for population-based research and for planning and for monitoring of services. It cannot be used to target services to individuals. It can be used, however, to provide the evidence about who might benefit from services so that practitioners on the ground can target their efforts more effectively. This slide shows the EChild database actually contains a number of different component data sets introduced at different points over the last 25 years. So hospital episode statistics, which are primarily used for monitoring hospital services and for costing, contains 5 different databases, but there are now many more databases routinely collected by NHS Digital and held by NHS Digital, and I'll return to this at the end. The National Pupil Database contains data on each school, from each school term, on enrolment, special educational needs, and absences and exclusions, and then all key stage assessments. And lastly, social care includes data on looked after children and children in need. This includes all referrals to children's social care through to interventions. But a very important component of EChild is the de-identified or pseudonymized bridging file that links together the pseudonymized HES ID to a pseudonymized pupil matching reference number, thereby linking HES data to education data within the ONS. This slide shows that the EChild, an important aspect of these data sets is that they are all longitudinal. And here is an example of a trajectory that shows how we can follow groups of children through childhood into adulthood. So in this example, we follow a child from birth, or groups of children like this, in the NHS through early admissions to hospital. This particular young woman has admissions for injury in early childhood and then for self-harm in her teenage years. We see that she gives birth to her first child at the age of 19 years. Adding information from education, we see that relatively late recognition of special educational needs, frequent absences in adolescence, and poor attainment at GCSE exams. at 16 years of age. When we add in social care data, we see a referral to social care services late on in primary school, and she then becomes a looked after child in her first year at secondary school. Children, actually, EChild can never pinpoint individual children like this, but it can answer questions about groups of children like this child. In this example, a key question is whether earlier recognition of a special educational needs or earlier support from social care could have led to different outcomes. We could try to answer this question using the variation in timing and intensity of SEND support across local authorities and across time, while trying to ensure comparability in health conditions and socioeconomic factors between these groups of children to minimize confounding. So EChild is currently being used to conduct policy relevant exemplar studies. These are focused on how disruptions during COVID have influenced education and health outcomes for particularly vulnerable groups of children. And we're defining vulnerability based on health characteristics such as chronic condition, education characteristics such as need for special educational needs or contact with social care. Moving on to governance, as this timeline shows, linking data across government takes time. Judgments and decisions are often reconsidered as circumstances change, such as the introduction of GDPR, and public support from early on is crucial. We started work on the predecessor data for EChild back in 2014, initially working with 3 children's charities. Their support was critical to the data providers and ethics committee. Our first request for this predecessor data involved just 4 one-year cohorts of children, which was just over 2 million children. This set the precedent for governance permissions and allowed us to develop the linkage method for the more ambitious EChild partnership phase 1 project, which is being led by UCL. This links all children in England born from 1995. And as I said earlier, that's nearly 15 million children. We've been able to access this linked data since June 2021, and we're now working on exemplar studies and linkage evaluation. Phase 2 is of most interest to this audience. This work is in progress on the governance arrangements for wider use of EChild for multiple research purposes by a wide range of researchers, whether from government or universities. This is making progress, and applications to access data should be possible in the coming months, and the data should be reusable over the coming years. EChild has undoubtedly raised the COVID pandemic has undoubtedly raised public awareness of the benefits of using administrative data. So we're in a different environment now. Over the last 2 years, we have been engaged with groups of children, young people and parents every 3 to 4 months, conducting facilitated meetings with small groups. And here we've been working with the National Children's Bureau, National Council for Disabled Children, and Great Ormond Street Hospital. In April of this year, we held a stakeholder meeting with 14 charities, funders, and government policy leads, as well as the data providers and researchers in the EChild partnership. This report highlights the findings of that meeting. There was strong support for EChild, but also strong support for safeguarding how data are used, for transparency about purposes, and a plea to make sure that these purposes are primarily for public benefit. Lastly, the EChild team has been active in giving talks to public, government, researchers and others about EChild, and we keep an updated news section on our website. I'll briefly now mention some of the linkage challenges and successes. Linking education and health data required linkage of real-world identifiers, full names, date of birth and postcodes. This was done by NHS Digital with support from the EChild team and particularly from Dr. Katie Harron, who designed the algorithm. Our paper reporting this method has now been published. In brief, Linkage required a multi-stage, multi-step algorithm, which was applied over all available years. Step 1 used identifiers recorded at each yearly school census and the full chronology of updated names and postcodes in the personal demographic service held by NHS Digital. So this is populated by GP registrations and attendances at hospital. Stage 2 involved linkage within NHS Digital data from PDS to HES, and at stage 3, we merged HES to MPD within the ONS secure environment using the bridging file. It's worth mentioning that an estimated 96% of all children in England are enrolled in state school at some point in their childhood, and hence have a record in the MPD database at some point. This graph shows the proportion of children in the MPD who matched to one or more HES records at some point. You can see that linkage improved in more recent years, which probably reflects improvements in data quality and the fact that after 1997, children were actually born in the NHS, so their birth record was there. In 2004, many more children were linked from their birth records than in previous years, but even for those born before HES started, 92% linked to HES at some point. However, we did find that children who linked at later steps and those who were not linked at all were disproportionately non-white and poorer. This emphasizes the need for the multiple steps in the algorithm and for quantification of linkage bias, so that where relevant, statistical adjustments can be made to account for mislinks among more disadvantaged groups. Lastly, I'll move on to future innovations. These are important to consider in this setup phase for EChild, as the potential scope of linked administrative data is rapidly changing and increasing. Least controversial is to improve the utility of the existing data. Here are two suggestions. First, enable linkage between siblings in EChild to one another, and linkage to one or both parents. Sibling linkage is useful to understand clustering of health and educational needs within the home environment. And this approach is widely used in the Nordic countries to control for clustering of unmeasured shared characteristics. Linkage to one or both parents adds important information on parental health, which is strongly associated with child health and educational outcomes, especially in the early part of childhood. Moreover, parental risk factors may well be amenable to policy interventions and interventions from services such as in primary care, social care, and schools, or to policies such as income or housing. These linkages can be achieved within EChild by adding pseudonymized links. The pseudonymized household ID, which is now widely used in Wales and in Scotland, and the mother-child link, which is used in hospital episode statistics and other health data. Another suggestion is to increase the precision of measures of income deprivation. The standard index of deprivation that we currently have measures income deprivation averaged across a lower super output area, which is roughly 1,500 individuals. This results in dilution bias, which underestimates the impact of income deprivation on child health and education. So it's really important to address this, as we're increasingly concerned about widening disparities and increased poverty as we move out of COVID. A second innovation is to add administrative data. The most important data set to be added from health is primary care. On average, children have 6 GP visits per person before the age of 5. GP data captures most mental health care, and it is widely used for research. Other data sets that could be added include secondary and tertiary mental health services, community health services, which include health visiting and disability services, and maternity services data. All these data sets have additional information over and above that included in HARES. However, their completeness, longevity, and quality are limited. So all these innovations will require ongoing support to maintain broad permissions and to keep the data research ready, meaning curated and documented. Additional data from education would also be valuable. EChild captures children's progress through schools up to the age of 16, but needs linkage to the individual learner record to capture the less academic educational careers of those who do not take A-levels. Linkage to higher education data would also be valuable, given policy needs to address inequalities in higher education. Linkage to the LEO dataset would also be useful to understand the influences of health, education, and social care on earnings and employment in adulthood, and potential points for upstream intervention to reduce inequalities in adulthood. The third innovation is to add surveys, cohorts, and trials, whether new or old. A major limitation of administrative data is that it measures contacts with services, not occurrences of events, experiences, or individual perceptions or opinions. Linking in self-report data from surveys or cohorts could therefore plug this gap. Self-report data is particularly important to capture information on the experience of school, on mental health, risky behaviours, neglect and abuse. Linkage of mental health survey data before and during and after COVID should be a priority. Many of these surveys could be linked to EChild using pseudonymized health or education identifiers without the need for accessing real-world identifiers. Lastly, consideration needs to be given to how EChild could be safely used for conducting trials without breaching rules against re-identification. Cluster randomized controlled trials are obviously one approach for this. EChild should also be considered for linkage to old trials in the past, to provide long-term follow-up on health, on cognitive ability through the school attainment measures and other aspects of education, such as absence. Careful consideration is, however, needed of how participants are informed of this use of their data and enabled to opt out if they wish. In conclusion, EChild is an extremely valuable data resource made possible by an academic government partnership. We are very excited about its potential to drive evidence for improved policies and services for children, but scaling up effective use requires safe and transparent governance and public trust. Ongoing partnership between researchers and data providers would help to maintain public trust and to drive the science for future innovation. Thank you.